We have a full agenda, unusual, but we have a full agenda. It'll be interesting today, but let's start with board member introductions. I'm Farla Kaufman, Chair of PHAB. You want to just unmute yourself and say hello and who you are? Board members. Hello.
Hi, my name is Phil Summers. I'm a board member.
Hi,
Hi.
Sarah Patel, also a board member.
Larissa May, also a board member.
Sandy Damiano, ex officio board member.
Jofo Borja, board member.
Libby Abbott, new board member.
Okay, I'd like to officially welcome Larissa May, one of our 3 new board members. Welcome, so glad to have you. The same is true of Libby Abbott, recently coming on board. So nice to have you attend and be a member. So welcome. Okay, so let's, oh, Emmanuel's here too. So he's a board member. Say hi, Emmanuel.
Hello.
And Steve Heath is also here with us, a board member.
Sorry, I thought
Okay.
thought I'd said hello, but my gardeners, the homeowners association, decided to show up with something approximating a chainsaw a little while ago, so you may not have heard me.
I know those things. Yes, I have neighbors who like to have their gardeners use those. Thank you, Steve. Okay, so we had a request to please mute yourself if you are not speaking, just so that we minimize the background noise. All right.
Hi, Farla. This is Nanda. I'm just listening into the board meeting.
Thank you. Thank you for joining. And I see also that Barbie has joined too, another board member. So welcome. All right. So we have on board the approval of March minutes. So I hope people had a chance to review the minutes. Are there any changes that people can suggest to the minutes? No, okay. Do I have a motion to accept?
Motion.
Manuel, second?
I second.
Okay, I think that was so now. All right, could you enter into the chat your vote on whether you approve, say aye or nay for no. Okay, we approve, Phil. All right, looks like 1, 2. Abstain, thank you. Abstain if you were not here. I forgot to mention that. Oh, yeah. Is anyone else having trouble with the audio? One of our members said they have trouble.
I can hear you.
You can hear me?
I can hear just fine.
Okay, so it might be Barbie's audio or someone else's. Okay, I think we have enough votes that the minutes were approved. Thank you. Just to update you on the vacancies for the board, we have currently 3 vacancies, even after filling 3 positions. So hopefully those will be filled soon. We have a couple of interviews that have occurred and one that will occur. So looking forward to that. Also there, just to let the board know again, and I'll mention this at another point in time, there are 2 advisory boards that have vacant positions for PHAB representation. So that's the first 5 and the Human Services Coordinating Council. They both meet once a month, I believe. I think the first 5 every second month, and one on the first 5 is on Friday from 2 to 3:30, and the Human Services Coordinating Council is every second Thursday from 12 to 1:30. And I'll try and schedule some time on the next meeting to just go over briefly what they do. So if anybody's interested, please let me know. Okay. Dr. Kassirier is not able to join us today, but she is being represented by Nick. Let me see. Nick, are you on?
I am here. Can you hear me?
Okay, Nick Moore. Yes, thank you. So thank you for being here to give the update.
Thank you for having me. Dr. Kassirier sends her regrets. She had something come up that she had to attend to. She did ask me to just give a brief update of the current status related to COVID-19. So first of all, we'll just start with some numbers. And if you follow our dashboard, this will look very familiar, but as of this morning, cumulatively, we've experienced 99,157 cases here in Sacramento County and 1,627 deaths. This latest number represents an increase of 115 new cases for today, which is actually much improved. As you may have noticed, we were making pretty steady gains in terms of improvements of our numbers really over the past couple of months. Things have been looking pretty good. The last week or two, things had slowed down. And in fact, we actually saw kind of a bump of numbers going up a little bit. So that was a bit of a concern. So this number of 115 added today is actually much more in line with what we had been seeing previously. It's a little bit lower, so that's a good sign. As I'm sure you're aware, the adjusted case rate of per 100,000 is what's used by the state to determine our placement on the blueprint for a safer economy, our tier level. And we've been in the red tier for a little while now. Our current adjusted case rate is 9.0 per 100,000. I believe yesterday we hit the vaccine equity metric of 4 million statewide vaccine doses administered in the healthy quartile index zip codes, quartile 1 zip codes, so the highest need zip codes, which shifts the criteria slightly. But in order for us to get to the orange tier, which has been the very popular question the last few weeks, let's see, we have to drop below a case rate of 6.0. We have to be at 5.9 or lower per 100,000. And right now we're at 9.0. So a little bit of work to do, but we're hopeful we're back on track and maybe can see that hopefully as soon as later this month. The other really popular topic, of course, is vaccinations, and we're seeing a lot of progress on that. Our dashboard includes a tab for vaccination information, and the most recent information on that, you'll see a total of 731,200 doses administered to residents of Sacramento County. And that's total doses, both first and second, for the vaccines that require 2 doses. But we have, at last count, 249,000, so almost 250,000 residents fully vaccinated, which is very exciting news, very promising. We continue to see new vaccine providers come on board. Vaccine supply of late has been improving. Our allocations have been increasing some. So capacity seems to be looking good. And as you, I'm sure, have heard, earlier this month, eligibility opened up to residents ages 50 and over. And on the 15th of this month, eligibility will be for all residents 16 and older, regardless of underlying conditions or employment. So that's very exciting. We have many partner providers conducting vaccine clinics, including California North State University, Sac State, Natomas High School, several retail pharmacies, many of the hospital systems are all doing their own vaccination efforts as well. We've been operating the Cal Expo clinic since the beginning of this year. And as you may have heard, we are transitioning that over to Curative, which is a partner organization that actually operates our McClellan site as well. So that site will continue to operate and continue to have capacity, but will be done by an outside provider, which just frees up some of our internal resources to focus on some more targeted events. We have been working on some of the more targeted events in neighborhoods and trying to reach some of the populations that may have more difficult time accessing the more traditional offerings. So hosting events at places like the Pennell Center down in Meadowview. We've worked together with the Farm Bureau and Walgreens on some events for farm workers, and are currently working on some additional farm worker outreach events. Last month held an event for the Marshallese community, a group that was particularly impacted by COVID-19 here in Sacramento County. We're working with the city of Rancho Cordova on a pop-up event at their city hall to reach some of the individuals in their community, and are also working on a large pop-up event down here in South Sacramento at the former Sears location at the old Florin Mall. A lot of information, a lot of changes for schools in the last few weeks. Schools, had been required to submit reopening plans to our office. When we moved into the red tier, that changed, and they're now able to open without any formal review. So most of the schools have either reopened on some level or are preparing to do so shortly. So we're very excited to see that. We have a dedicated schools team that continues to provide guidance to the schools on a safer reopening. And so I think things are going pretty well on that front. One area of concern is that the state did make some changes recently to allow for school athletics. And we have seen quite a few cases and some outbreaks within some school athletic teams. So we've been working closely with schools to both address those outbreaks and cases, but also really try to encourage safer practices, both with their sports practice, but also their games, to try to limit the likelihood of spread within their school community. And then, of course, some other exciting news that I think folks probably heard about yesterday. The state has announced intention to move beyond the blueprint. Ideally, it looks like June 15th. So really getting away from the blueprint and the tiers, hopefully lifting most of the restrictions that are in place at that time. The thought being that we should have significant vaccine availability and hopefully, significant number of residents vaccinated throughout the state, that we can start moving towards allowing more and more activities, such as we did pre-pandemic. So with that, I think I'll stop there. If there are any questions, I'm happy to try to answer those. And if it's anything I can't answer, I'll work on getting an answer and get back to you electronically.
Nick, I did have a question. What's the percentage of the population that's already vaccinated? We have that. I know we have 250,000.
Yeah, we were just discussing that this morning. I'm not sure so obviously our population is about 1.5, 1.6 million for the county, but that includes children. And so I'm not sure what percentage of our population is children and therefore ineligible to be vaccinated. But I think we thousand total doses. So we can assume that a lot of that difference from that 731 to the 250,000 are people who are in between, and hopefully have gotten their first dose and are just
Any other questions for
Yeah,
Nick?
this is Libby. Thanks, Nick, for the update. I'm curious whether the county has been able to track wastage of vaccines. I think it's something we hear about in the news and maybe even anecdotally. And I'm wondering how you've been able to monitor that and what sort of strategies the county is taking to try to reduce that and get vaccines to the people who need them as they're available.
Yeah, that's a great question. And I know that does come up in the news a lot. And I think if you're active on social media, you see reports of like, I envision dumpsters worth of vaccine being thrown away based on some of the reports I see. I only have anecdotal evidence just based on the conversations I've had with our vaccine programs. And it sounds like, at least with the providers that we've been working with, from what I've heard, pretty minimal wastage in that, you know, everything to this point is by appointment only. There are no walk-up clinics, which, you know, makes planning for a clinic pretty straightforward. You know exactly how many people are supposed to show up, and really the kind of the extra dose piece really just comes down to no-shows, which I think for many places is not significant. But I don't have any hard stats on number of wasted doses. I do know, in talking to our vaccine program, that many providers might have their own mechanism for getting those quote unquote extra doses out. So if it's a retail pharmacy, it might be, you know, a PA announcement to just whoever's in the building, if, you know, if they want to get vaccinated. I know some of the urgent care places I've just seen online and on Reddit and other social media where people report just showing up there at the end of the day and kind of waiting around to see if they have an extra dose. But I certainly haven't heard of any wastage or doses being thrown away. But I can ask to see if we can get any kind of firm data on that.
Well, it does sound like good news. That's really good to hear. More vaccination sites. Hopefully we'll have enough vaccines to keep all of them busy. So that will be good. Thank you. Thank you very much for the update.
Thank you all.
Okay, so next on the agenda, we have primary health update. Sandy Damiano.
Yes, good afternoon. I'm sorry, I'm having a little bit of video problems today, but just a couple updates on programs. For our WIC clinics, our county WIC clinics, our March caseload was over 100%, 101.9%. Ever since they went through COVID and have been doing the phone appointments, it's been extremely successful with a lot of members, families participating. They also began participating in the statewide rollout of the telehealth pilot, which is happening finally. It's been long awaited, and I believe that telehealth program will be beyond the COVID pandemic because it's really helpful to families. In terms of juvenile correctional health for COVID data for the week of March 28th, they've had a total of 29 cases throughout the entire pandemic. They had 2 active cases last week, and their census is running a little higher than normal at 105. They're trying to prepare for accreditation, so a lot of their work is focused in that area. For the jail adult correctional health, I have brand new data as of today, so it's not posted yet on our website. Total COVID tests throughout the pandemic is 14,381. So we did about a little over 329 tests this past week. Our total net of confirmed cases was 4 for this week, which is great and is a decrease from prior week of a net increase of 7. As of this morning, we had 4 COVID confirmed cases in the main jail and 4 at the branch jail that are in the COVID housing. In terms of our vaccination data for inmates, that's one of our areas that we're ramping up. Data as of yesterday, I guess yesterday afternoon, we've administered 1,386 vaccine doses to inmates, and we have 983 are fully vaccinated. We are doing much better with the vaccination series with the Janssen vaccine. So that is our hope, is that we continue to get more of the Janssen. We do still have some Moderna. We are getting inmates transferring in from county jails or prisons that are on Moderna and need their second dose. Today, let's see, in your agenda, you're going to hear from Brian Jensen, who's the Regional Vice President of the Hospital Council. He presented to the Board of Supervisors on February 9th on behalf of the Emergency Medical Advisory Group, which created a fiscal work group. That work group is part of our Emergency Medical Advisory Group, and they wrote an outstanding paper, which I think was distributed to you. And they are clearly expressing needs to enhance funding and staffing in order to improve the quality of care within our local emergency medical system, which impacts all of us who reside in Sacramento County. So I'm sure you're going to enjoy his presentation, and I hope that his paper was routed to you. I did not see it on the routing, and I think that's it. I wanted to make sure we gave most of the time to Brian today. And I did send to Farla some comments on the Board of Supervisors letter that she circulated, I believe, right before the meeting. I think that's it for me.
Farla, you're muted.
Okay.
I can't hear you, Farla.
Thank you. Yeah, it's just I was spotlighted and now I'm unmuted. You can hear me now, right?
Yes.
Oh, good. Okay. So we have the agenda as we move on. Thank you for giving some background to Brian Jensen's talk. We will get to it after. And right now I'd like to bring up the letter that was circulated, the draft letter, and as well as some comments and responses from Sandy. So I hope everybody had a chance to review those. And I guess we can
This is Sandy. I also wanted to say that the comments were not just from me. There's comments on there actually about the Sheriff's Office and Adult Correctional Health. And then comments made in red are by our Criminal Justice Planning and Coordination Analyst, Catherine York, who's present today as a member of the public.
Okay, thank you. I'm going to open it up for discussion because I think there'll be a lot of discussion, and perhaps I can bring up, while we open it up for discussion, maybe I can get the letter up on the screen. Let me try and access that. I think I have to.
So for folks that are interested in making comment, if you could indicate in the chat that you're doing so, and we'll create a queue. If you can't chat, just either raise your hand on Zoom or you can unmute and let me know and we'll add you to the queue.
Okay. So let me just give a bit of a background while people are formulating their questions. We had a presentation previously last month. It was the whole meeting was centered around the county jails, and we had representation from Correctional Health and the Sheriff's Office. Sandy Damiano facilitated their participation. Thank you again. And also participation from the community in terms of community members and an organization called Decarcerate Sacramento. And although we didn't have a lot of time for discussion, there were some very compelling comments from the public. And the board the executive board has reviewed this letter that was drafted by board member and circulated to you for your comments. the procedure for PHAB is to advise the Board of Supervisors. And we do this mostly in terms of these correspondence as letters. And this was drafted as such, meant to be sent to the Board of Supervisors to let them know of what advice we feel we'd like to convey to them. So when we do this, we draft the letter and it must be brought to the board for comment and subsequent changes, and then a vote occurs whether the board supports sending the letter to the Board of Supervisors. So that's where we are right now. We're bringing it forward to the entire PHAB board for comment and suggested changes or whatever, and then possibly a vote today on that. Hopefully we will vote on whether to send it or not. So that's the background for the letter. So I know some people have comments. I'd like to open it up for those comments. And I think I want to also preface this by saying this is a very complex issue. There are a lot of moving parts here. There are a lot of players, authorities that have jurisdiction over one area and not the other. The Board of Supervisors doesn't have jurisdiction over everything either. And there, due to the consent decree, which was a settlement, this was part of the settlement that the county had entered concerning a lawsuit against the county because of the jails. So it's been in effect for a while, and the county has been moving forward to complying with a lot of the conditions of the consent decree, but it is very difficult because of the conditions that existed before and the hundreds of changes that are needed. And so there's been a lot of progress, but as we heard last month at this meeting, there are a lot of things that people are very concerned about, and that's why we're here. I understand that in response to some of our comments that were drafted in this letter, Dr. Damiano has compiled these responses from the different parties, and we appreciate that, and we appreciate all the effort and all the progress, but we still, I think, are concerned about the issues that we were hearing about, and some of them are, as I said, not, they're very divergent from what the policies are in place. People's experiences are divergent. So that's our concern. And it's very hard to understand what policies are being enforced as per their definition, and where the resources aren't sufficient to fulfill those policy changes. So given that, I turn it over to people for comment. And I think there's some comments in the chat already. A copy of the letter is on the PHAB website, but as I said, in a minute, I'll try and bring it up on the screen. So give me a chance here.
So Farla, you do have one person that's signed up for comment, Libby Abbott.
Initially, people can just raise their hands or unmute themselves to comment. If it gets a little busy, we can change that procedure. But Libby, go ahead.
Excellent. So this is sort of a combination of maybe a comment that segues into a question. I'll try to be short with it. There's a lot to this issue and a lot in the letter, but maybe to try to summarize what stands out as one of the biggest points for me. So I think we had the commentary from Decarcerate and the inputs from the community that were really valued and sort of presented one picture of the situation. We then had the responses from Sandy Damiano, ACH, and the Sheriff's Office, which sort of counter that version of the current situation. And I wonder if it feels a little bit like there's a kind of two sides of the story right now. And what I wonder if the best place for PHAB to position a recommendation to the board is really around monitoring and oversight, getting to the bottom of what is actually happening, what is the current situation, are there hygiene and sanitation supplies, do inmates actually have timely access to testing and treatment. I don't think we can answer those things for ourselves. I feel like there's an allusion to the existence of current sort of monitoring and oversight systems in the letter, but where I have a question is I'd like to understand a little bit more about that. If Sandy Damiano is able to speak to that, what is currently in place? How frequently does monitoring and oversight take place? Are those findings publicly available? Can we leverage those to make more targeted recommendations to the board to be really action oriented and make sure we're responding to a true picture of the situation and highlighting sort of available actions? The second part of that is there's reference as well to existing action plans that are owned by ACH as part of the consent decree. And I'm wondering if there's specifically monitoring and enforcement of those action plans. And if, again, that's where we can come in and push for a recommendation to either drill down on those action plans, again, monitor or audit those action plans, or accelerate them as required to respond to the current situation with COVID, which was not the case, I think, when the consent decree was published. So it's a lot of sort of questions and comments at once, but hopefully it all ties together.
Okay, I can try to answer part of it, and I might not get the whole thing correctly. I'm not saying, and I don't think the sheriff's office is saying we're in compliance. I don't think that's it at all. This is going to be a multi-year plan to implement the changes. Change, when you're doing major culture changes, they don't necessarily go smoothly. You have staff that have worked in the facility for years. There's a lot of training, retraining, there's staffing issues and that sort of thing. So it will take time. Some of the COVID protocol, and that's what we were asked to talk about. If you recall, last month, we were asked to speak very briefly about COVID. We didn't know that the scope of the meeting was larger. It wasn't until the presentations happened that that was discussed. What I can tell you is the COVID has been an evolving process. I think we've done 15, 16 revisions of the guidance, and those changes occurred over time. Obviously, we've done a tremendous amount of testing over there, 14,381 tests. Some of those inmates or patients have been tested multiple times. So testing does occur. Were we always in the very beginning testing people and then informing them of the test results? No. So this is changes that have occurred through time to make that happen. As we find issues that may be of concern, for example, one of the items that you brought up was inmate masking at the meeting. I think it was inmate masking or something. Those items are brought up to the sheriff's department and then they work on it. I did see witness email chain. I asked about it, inmate masking. I had heard something from one of the doctors. Immediately, one of the lieutenants showed us what they had done to rectify it. It was based on a one staff situation, not having information, tremendous amount of masks. The cleaning practices are ongoing in the facility. So I'm not sure what more I can say about that part. For the sheriff's department, they cover certain areas like the sanitation, inmate masking. We do bring things up to their attention, and we do that on a weekly basis when we have our COVID procedure meetings. Regarding our monitoring, we have a group of counsel, plaintiffs' counsel from the Prison Law Office and Disability Rights. They're extremely involved in meeting with their inmates, taking calls from the inmates, complaints. They come on site, they've interviewed them in small group individually. We have 2 medical subject matter experts that are familiar with jails and the protocols and the remedial plan. We have a mental health expert, psychologist, and we have a suicide prevention psychologist. All of plaintiffs' counsel and all of the experts have access to any of our policies, procedures, and we're constantly updating and providing deliverables to them. Additionally, they all have access to the electronic health records. So when we say we've implemented something, they look. And if there are inmate concerns, they bring it to our attention. So we are constantly in a dialogue with either plaintiff's counsel or with the subject matter experts. So we have a high degree of monitoring. We will be having the medical experts on site coming up here shortly again. We are presenting our action plans to the plaintiff's counsel and all of the experts in conjoint meeting, Zoom meetings coming up. So I would say there's a tremendous amount of oversight that is occurring with this remedial plan. I don't know if that answered the question. Oh, in addition to the experts, the PLO DRC, one of the things that the Adult Correctional Health Program did not have historically was a quality improvement unit. So that's a brand new unit we created, I think, a year or two ago. We also do data, which they never had. So we look internally as well as relying on the subject matter experts. And we are providing corrective feedback, which could be in the form of staff education, staff training, or staff corrective actions when they occur. One of the items that we're rolling out right now, which is really big, there are a number of policies related to patients with disabilities and effective communication. So I think we did 7 policies in this area. It's a fairly complicated area. And we're in the process of doing mandatory training facility-wide. And I did tell the managers today that when the training's done, QI will start doing their audits, starting at the intake end and looking at those ADA issues. So that's just one example of us internally rolling something out as well as having experts review it. I'm not sure if I answered your question, Libby, about the monitoring, self-monitoring and monitoring by experts.
Yeah, it certainly gave me quite a bit more information.
Okay.
I'd be interested to hear from others on the board as well. I mean, I think,
sure.
And I take your point that there's a little bit of conflation between monitoring of what needs to be in place as a response to the consent decree versus monitoring sort of the COVID situation or the specific issues that were raised on last month's call.
Okay.
But it still sort of leaves me wondering what we as PHAB can do to reconcile the fact that the community is expressing one particular picture.
Okay.
Hearing something else from you.
Yeah, I'd like to respond to the COVID. So our medical experts reviewed all of our COVID. I send them a detailed email every week on our COVID data, our vaccination data. They have our COVID guidance from the correctional health and from the sheriff's office. When they see our guidance or our policies, so for example, if we draft a policy in a certain area like medication for discharged patients, we give that to them to see if it's compliant. They will make edits on our process and we need to incorporate those if they're not clear enough, etc. I don't want to diminish anyone's experience that they've had historically in the jails. This was a brand new experience for me coming to work and have oversight of the jail. So I don't want to diminish anyone's experience from what they've had in the jails, nor do I say that there was what they reported happened with COVID did not happen. Because as I said, the process has changed over the year. I guess we've been in the COVID now a year and 1 month. It's changed over time tremendously. So again, I'm not saying that what they've experienced is inaccurate.
Sure, that's helpful. And I'd like to just give some thought to what that means for me, but would love to hear from others.
Are there other comments from the board members? Are there comments on the initial letter? Or any other public comments?
Farla, this is Sandy again. I know a lot of the presentation, and it might have been at this meeting or it might have been on the jail facility meeting. A lot of people had comments about the alternatives to decrease the jail population. And I did want to say, from a health perspective, a health and mental health perspective, we would appreciate a reduced population. We have nothing in disagreement with that whatsoever. It makes it much easier for us to manage because we don't have as much staff as we need. But I know Catherine's also on the line, and same with Jim Hunt. So if there are any questions about some of these strategies, I know board members were very much interested in those. One of us could hopefully answer those questions. I think they started on page 3.
Yeah.
But
yeah,
that's a very complex issue as well.
Yes, it is. However, it's very disconcerting. We saw a decrease in the jail population due to COVID when the outbreak occurred initially, and now the population has increased again. So I'm not sure how effective these.
Yeah, I can respond to part of that. Back in March or April, when all of us were dealing with the big unknown called COVID, there was a tremendous effort by the Sheriff's Department and by the courts to reduce the jail population. And we must have reduced by, I don't know, over 1,000 inmates. And so it went down to like 2,300 or something like that. And for those of us who work in the jail and we're working on COVID and working on other things, it was wonderful. It was absolutely wonderful. But I think a lot of the jail population, from what I know, and again, this would be, you really need to talk to the Sheriff's Department. They've really taken out almost all the misdemeanors. They've taken out what they consider to be the population that can be in the community. Not to say that there aren't still some that could be there, but I think that has happened. The CDCR, the prison system, in response to COVID, really stopped transfers from county jails of sentenced population going into prison or going into state hospital. And I know for a while that, and Catherine might know this number, but for a while that was like 500 or 600 people were in the jails pending transfer to CDCR. They were cleared by the courts to go, they were ready to go, and yet they were still in the county when we were dealing with a COVID situation, but the state had said no admissions. I think that's picked up, but very slow trickle of people leaving the jails to go to prisons.
This is Catherine York. Can you guys hear me okay?
Yes.
I just wanted to respond to what Sandy said. There is in fact a large proportion, nearly 20% of the population sentenced to prison, that cannot be transferred to prison because of their intake protocols with COVID. And as recently as last week, they took 90 additional inmates that were sentenced to prison, but we still have nearly 600 people in custody who are sentenced to prison. In addition to that, there are federal inmates that we don't have control over who goes and stays relative to their pretrial status. So the county is doing, as well as the courts, as much as possible to keep out anyone who can safely be kept out of custody. So the people in custody are in there for serious felonies.
Catherine, can you say how many federal inmates there are? Because I can't remember.
It's about 10% of the population, nearly 310 today.
Okay, so I think this morning our population was like 3,300. We have 600 waiting for prisons and another 310 that are federal detainees. That's a lot. That's 900 people.
Yes.
It is a lot. But again,
there's also no one getting admitted into the state hospitals who are pending restoration of competency. That list is growing as well. There's about 100 people on that list.
Okay, so that's 410 right there.
So, oh, Phil, did you want to say something?
Yeah, I think this, especially in the context of this pandemic, I think the jail population, the daily population is a super important metric to think about. And I know that there are a lot of really complicated, high level policy changes and these pretrial programs, and obviously like, folks that are destined for prison that are getting held up. And there's a lot of push and pull that is, very much above my pay grade and our pay grade as a board, I think. But I'm also curious about kind of the local discretion that kind of is available. And just thinking about some of my experience as an emergency doctor, we get a lot of patients that come through for medical clearance. And anecdotally, again, like I just witness a lot of people that kind of come through the emergency department, and they're the officer will say, I need medical clearance so I can book this person. I'll identify some abnormal lab or abnormal vital sign that requires additional workup. And then, it's often the officer will say, we'll just set him and release him. Then I don't want to wait around for it. And so it like from that anecdotal perspective, it seems like there's a lot of discretion locally on kind of who gets booked for these, short stays that may or may not be necessary. And I'm wondering if there is kind of room to explore some of those avenues for where that discretion exists, and some of these policies and maybe some of these incentives that exist for some of these officers, as to whether or not they book versus cite versus kind of what that decision looks like. Because it seems, in my anecdotal experience and my colleagues, it kind of seems like a pretty substantial proportion that are kind of left to that discretion that appears arbitrary from my vantage point. And I assume there's more explanation behind it that I'm not aware of.
Catherine, can you tell them how many cite and release we had last year? I think it was huge.
Yeah, approximately 30 to 35% of all bookings are cited and released. That's the historical average in a normal year. So 2019, 37,000 bookings. So 35% of that were cited and released. And what happens is I can't speak on behalf of the law enforcement agencies, but they all know that most low-level offenders will be cited and released, but frequently there's an offense that they're arrested on, which is not necessarily the offense the DA files charges on. So there's a different decision point that affects what the jail staff can and cannot do. So when the DA, within 48 hours, they have to make a determination whether or not they're going to file. And that charge that they file on will impact whether or not there's a ability to cite and release.
Yeah, that's helpful context. And yeah, I just think more broadly, I think a lot of these, just a lot of these short stays, especially in the context of this pandemic, are just, it's concerning. It just seems like an inevitable, or it seems like an avoidable risk, especially in the context. So,
sorry to interrupt, but the court has issued standing orders for law enforcement to cite and release certain offenses that previously would have been booked into jail. So you can go to the court's website and look up the standing orders that have been issued by the presiding judge, which includes the zero bail order, which our county opted to extend beyond the state order requirement.
Okay, well, just one aspect of many complicated aspects of this issue. But thank you all for
Chair Kaufman.
Yes, Joe Phil.
Just one last comment. I just wanted to, I know we're limited to kind of our sphere of influence on the public health arena, but I think it may be worthwhile to maybe at the end of the letter, my recommendation is to kind of bridge a message of partnership with the county, but also kind of relate back to previous endeavors by certain chairs of the county to provide either a citizens oversight commission on top of the sheriff or some sort of office of inspector general that would have the ability to really mitigate and or examine these types of complaints on a long-term process, not just by COVID, but I think a lot of these problems are inherently continuous pre and post pandemic. And so I just don't know if within our social equity lens, whether or not that is a determinant of public health to have better citizen oversight of our law enforcement partners. But time and time again, previous chairs like Kennedy and Serna have tried to bring this in. And I just don't know if that's a valid comment that we can make on behalf of PHAB on the letter. But this is not a new issue. I feel like this is just more or less another matriculation of the problem that I think really needs to be fixed, kind of a little bit above PHAB.
Thank you. Yeah, I tend to agree with you. And yes, there is an Inspector General at the Sheriff's Department, and yes, Supervisor Kennedy has recommended some sort of oversight. I don't know where that stands currently, but it certainly seems like it would be a very useful entity to have, and we can add that to the letter. So bringing us back to the letter.
Carla, it
yeah.
looks like you have one more. Sam's had her hand up for a while.
Okay, so we have, I'm sorry, I didn't see it. So we have a couple of minutes left. Could you, Sam, would you like to make a short comment, please? Thank you. Sorry for that.
Yes, thank you. I'd like to echo, first of all, what Jofil Borja just said about the oversight. That's an excellent idea. And it feeds into my comment, which is that on point number 6 of this letter, the initial point number 6, it says very clearly here that the inmates, that incarcerated individuals must be assured that custody staff also follow public health guidelines in Sacramento County's COVID-19 containment policies and are held responsible for their behaviors. Admitting here that indeed the latest outbreak may have been due to a lack of such adherence on part of the staff. And I understand that our focus is on the health and wellness of incarcerated individuals, as it should be, but I'm wondering about what sort of oversight, what sort of record keeping is internal to the staff and county and sheriff's departments about their own numbers, their own data on COVID, their own protocols for mask wearing and distancing and protection of inmates, and if those records are made available, if there is some standard on paper somewhere that we can know about. Thank you.
So the Adult Correctional Health has staff guidelines. If PHAB wants to see those, I can send them to Farla. The Sheriff's Department, I can't just give you their guidelines, but I could ask them if it's okay to send them to you as well, if that's what you're wanting to see. But we do have COVID guidelines. These have been reviewed by our medical experts from the jails. This is a doctor and a nurse practitioner that specialize in correctional care within either jail or prison.
Yeah, that would be helpful, and we could have it posted on the PHAB website. Steve, we're running out of room. I see your hand. We're running out of time. Quickly.
Okay, just a very quick comment. I have been impressed over months now with Dr. Damiano's plans for the jail and her implementation of those. And I imagine it must have been very frustrating when the outbreak finally started to occur late in the year. And Sandy, I'm just wondering whether you are happy yourself with the oversight in the jail. Somehow all of this occurred despite the best of plans. And from the reports that we had last month, many of those may have been due to the custody staff lack of adherence with those plans. So I'm just wondering whether you yourself are happy with the oversight within the jail of some of those behaviors.
So what I can tell you about the COVID, it's very, very challenging to monitor COVID, do all the strategies in the jail settings. These are not healthcare facilities, they're correctional institutions. Particularly the branch jail has this barracks dormitory style. From talking with Dr. Kasiri, what we saw happen during this outbreak period is not uncommon. It's not uncommon in the jails, it's not uncommon in the prisons, and it's certainly not uncommon in long-term care facilities. Yes, we were extremely disappointed after having done so well for so long in terms of keeping it at bay. But once it spreads like fire, and then trying to get it contained again was a huge effort. As I said, we had weekly meetings with the command staff, leadership, with medical, our medical director, nursing director. I facilitated the meetings with both captains, the compliance lieutenants. We had meetings outside of those meetings to problem solve barriers, whatever we could do for both the branch jail and the main jail, because their physical plants are so different. Additionally, we had meetings, and we still have meetings with public health every week. The nursing director and I meet with Dr. Kasiri and her staff every week. And we had meetings with our medical experts and the prison law office disability rights on all of our COVID protocol and on the outbreak. So I think we did the best we could. Wish it didn't happen. We are in containment mode at this time, and our goal now is to try to get the vaccines done as soon as possible to mitigate any future outbreak. And we do report out when we hear of non-compliance, and when staff do their walkthroughs, we tell them what's non-compliant. We do that for our staff as well. We've had very good luck with the medical staff who work in all the COVID wards. Extremely little COVID amongst the medical staff. So I'm very pleased about that, because that means all of the protective things that you do work, which is what they're supposed to do. So thank you for that.
Thank you. Okay, so we are running very late. My consensus is that, well, let me ask very quickly, do people feel like they want to vote on this letter, or should we call another meeting to discuss it a little further? Because we need to hear from our guest speaker today. I'm not hearing any.
Carla, this is Libby. It feels to me like even just from Sandy's written responses, we would probably need to revise the letter and reconsider, but I'm very new to this process, so that's just sort of my reaction. Happy to hear from others.
Thank you. All right. So in the interest of time, I'm going to suggest that we table the letter for a meeting that I will call in the next week or two, for a very short meeting, hopefully, after we revisit this issue. I hope the members will consider Sandy's remarks and our original written material and perhaps added material suggested by Joe Phil for additional oversight. And we can explore this a little bit more at that time. So are there any objections to calling a special meeting? Hearing none, I will take that as none. So now we'll move on, and I'd like to turn it over. Thank you, everybody, for your comments. Thank you, Sandy, for all of the responses, and Catherine York for being here and helping to inform us. We will continue to explore this and hopefully get some more focus on this. Okay, so without further ado, I turn it over to Brian Jensen, who's joined us today from the Hospital Council, and Sandy had given him a fairly brief but good introduction. So Brian, please unmute yourself, and I think you have the ability to share your screen.
Okay, well, welcome everybody. Greetings, everybody. I appreciate you welcoming me into your meeting, and I recognize that you're probably bumping up against time constraints and so forth. So I will try to be concise in my comments with you. I'm going to, as Farlow said, share my screen with you. So please bear with me just a moment. All right, do you see the the emergency medical services in Sacramento County?
Yes, we do.
All right, very good. Well, I want to just briefly let you know who I am, why I'm on your agenda, and jump into an issue that may or may not be familiar to some of you despite your involvement in healthcare. This is kind of an issue that tends to fly under the radar, hence our efforts to make people, including the Board of Supervisors, aware of what we see as a growing problem that needs to be addressed in Sacramento County. So again, I'm Brian Jensen, and I'm the Regional Vice President for the Hospital Council, which is an organization that represents all the hospitals and health systems. And really what I do every day is pull together smart, dedicated people in healthcare and related fields to try to tackle some of those more challenging, thorny issues that no one organization can fix by itself. So it's really about collaborating and innovating to address really complex problems. And so to give some context of how we got to this point, about 2 years ago, the county released some proposals for new and increased fees on hospitals, as well as EMS providers, emergency medical service providers, both the fire service and private ambulance companies, for various purposes. And the reason was to help expand the staff at the Sac County Emergency Medical Services Agency. So I'm going to just say EMSA from here on out to be brief. So if I say EMSA, I'm referring to Sacramento County's Emergency Medical Services Agency. And as we, both on the hospital and pre-hospital provider side, were taking a look at these proposals for new and increased fees, we came around to the point of supporting those fees and those increases, despite the fact that no one ever likes to have new straws in the drink, so to speak. Yet we understood the importance of them. But what became even more concerning as we really dove into those conversations was that the needs of the EMSA were beyond that which were being addressed by these new fee increases. And that even with those fee increases, it really wasn't going to get to the underlying problems that we saw within the agency, the EMSA. So that led to the creation of the Emergency Medical Advisory Group, which is a body that consists of leaders from both the pre-hospital provider field, so fire districts and fire departments, as well as private ambulance companies, as well as the local hospitals. And the idea was to come together as thought partners with the county to really tackle these issues and see what kinds of recommendations we could come up with. And that's what is found within the report that I believe was shared with you, and which I'm going to give you a brief synopsis of right now. So what is the EMS system? That basically consists of the 911 dispatch. When you have something go wrong, you call 911, someone takes that call and then routes it to a responder. And then in terms of healthcare response, that goes to an ambulance provider of some sort. And there are several within the counties. There are several fire districts and fire departments that provide that 911 service. Also, there are private ambulances that do other sorts of inter-facility transfers. But when you call 911, the ambulance can take you to one place, and that is the hospital emergency department. So when we refer to the EMS system today, that's what I'm referring to, is that those folks who respond when you call 911 and take you to a hospital emergency department. Now, you're probably familiar with that. Hopefully you haven't had to experience that personally, probably, though someone you know and love has. What is lesser known, even within a lot of healthcare, is the role that the EMSA plays, which is what we're addressing today. So the EMSA really plays kind of a coordination role. And it's just a small number of people who do a lot of connecting of those large and multiple and complex healthcare systems. When you talk about large healthcare systems, you talk about 13 different ambulance providers of different sorts within the county. That is all coordinated by the EMSA. There are protocols in place to govern how they operate in emergency medicine. They do the certification of EMS personnel. They validate EMS training programs. They make sure that there's a unified and coordinated way of going about responding to things. When there are disasters, both in the planning, kind of the prevention space, as well as in the response space, the EMSA plays a really key role in coordinating those efforts. They play referee amongst agencies in this system, whether it's the ambulance provider or the hospital. It also just makes sure that there's good data analysis, good communication about how to best provide care. Because when something bad happens, you have to call 911 or someone has to call on your behalf. You want to make sure that you get timely, accurate, good quality care, no matter what. So those are all hugely important. And there's another role that the EMSA plays, and that is the Medical Health Operational Area Coordinator role. MOAC is the acronym. And what the MOAC does is when there is a disaster that requires personal protective equipment, specialized equipment or other kind of equipment, it requires additional personnel to respond. The hospital will, or the ambulance company will call the MOAC and say, hey, we are out of whatever. And what do you think happened during the beginning of the pandemic? There were runs on personal protective equipment. There were shortages of certain kinds of specialized personnel, respirators, and all those kinds of things were in short supply and in high demand. And so the MOAC role was really highlighted. And I'll tell you that was a vital service within the healthcare response to the pandemic. So why are we here? Why did we come before the Board of Supervisors a couple of months ago with this report? Well, as we dive into things, the demands for service from the EMSA, Sac County's EMSA, is growing dramatically. You know that there's natural population growth within the region, and we have more people here today than that were here 10 years ago or 20 or 30 years ago. There has been a dramatic increase in the number of programs that are designed to train healthcare personnel. In 2014, there were 11. As of 2019, there were 37. So they have to have someone go out and monitor and audit those programs to make sure that they are effective and accurate and high quality. And then there's just a dramatic increase in the number of transports via ambulance. So I'm going to just show you this chart. So in 2013, there were 207,000 transports. As of 2019, just over half a decade later, that number was 324,000. Just dramatic growth in the demand, the strain on the EMS system. Now, the numbers for 2020 are going to look a lot lower than that because of the pandemic, and a lot of people avoided seeking out healthcare, which is a whole different problem. But you can see that the course we're on is the existing system is just straining, and the oversight and coordination that is provided by the EMSA hasn't expanded with that growth in demand. So what are the core problems? Sacramento County's Emergency Medical Services Agency is underfunded and therefore understaffed. Despite those new fees on hospitals and ambulance providers a couple of years ago, they are dramatically underfunded and understaffed. So beyond that, the prospect is not good because the primary source of funding to this point is also deteriorating. So this chart that you see is a comparison between Sacramento County, which is on the far right column, with 1.5 million people, more or less, and 4 comparable counties, Alameda, Santa Clara, and Contra Costa are also Northern California counties, roughly serving a comparable population. San Joaquin is a little bit different, and I'll point that out in just a second. But those 3 Greater Bay Area counties that I'm pointing to on the left columns, you'll notice the bottom line is that their total staff is 24, 21, and 15. For Sac County, it's 7.5 full-time equivalent. That means Sac County has 1/3 to 1/2 the staff of its most comparable local emergency medical services agencies. San Joaquin is that column right next to Sacramento. It's there for a different kind of comparison, it has roughly half the population or less than half the population of Sacramento County, and it has more staff, 10.3 FTE compared to 7.5 FTE. Now, I'm not advocating for the growth of any bureaucracies, just having numbers to have numbers. That's not what this is about. I think what this shows, though, this is not just about being mean and lean as an organization and avoiding red tape and bureaucracy. This is being understaffed. And when you look at the revenue sources for the agency, 75% of the funding revenue for the EMSA comes from the Maddie Fund and the Ritchie Fund, which are, they're basically, when you have a moving violation, you get a speeding ticket. No, I know none of you would have a speeding ticket. Imagine some hypothetical person would have a speeding ticket. The base level fine might be $200 or $250, but what the person is asked to pay may be double that because there are these tacked on fees. Well, that source of funding, which we call the Maddie Fund and the Ritchie Fund, constitutes 75% of the EMSA's revenue. So what has happened over the years recently is that the courts have started to kind of unravel that and not require the collection of fees on people either fully or at all, which means we're banking on money that is not appearing in the way that we had anticipated. So that means that our future is even more bleak. So what is at stake for Sacramento County? What does this all mean? Well, I probably haven't done a good job yet of really bringing out exactly why the EMS is important. Because it's not something that the general public interfaces with at all. Unless you're in the business of operating an EMS provider or a hospital, you normally haven't experienced it. But there's an element of public accountability that takes place when, let's imagine you or a loved one has a bad experience with an ambulance crew, with a hospital. Who do you go to? Well, you appeal to the EMSA, and they perform investigations to determine whether the county EMS protocols were followed or not, and to what degree there may have been problems. And it helps lead to better training, hopefully not a whole lot of negative consequences for people, but usually it's about corrective action and making sure that those problems don't occur again. So there's a public accountability role that is being missed because, frankly, the only person who's really trained to do this in the EMSA is the administrator who's running all the rest of the agency as well. And so there's a potential for investigations getting short shrift. Now, there is an increased strain on hospital emergency departments because of this lack of EMSA staffing as well. It means the hospitals are having to do more of the data production and analysis on their own. A lot of staff time is going to crunching numbers, and the data analysis is all about quality assessment and quality improvement, because you can really see where there are trends, where there are gaps, where people are maybe not getting the timeliest response, where people are getting better outcomes because certain protocols were followed, and it leads to being able to tighten up those protocols or make sure that the best medical knowledge is being applied in the field. So there's been a tremendous administrative strain on hospital staff because of the lack of EMSA staffing. Destination oversight and enforcement and compliance, making sure that all the policies that are in place are followed, and when not, that there's corrective action in place. Something that you can probably just intuitively relate to is disaster preparedness. Now, Sacramento County traditionally has had a number of, we're primed for a number of kinds of disasters. Significant flooding, we're in a wildfire tangential zone, and not so much in our county directly, but for sure in the region. You can have a mass casualty event on a freeway, a terrorist act at a dam or an airport. There are all sorts of things, let alone a pandemic. Well, it's been about 20 years since the disaster plan was updated. Well, what has happened in the last 20 years in the Sacramento region? What has changed? A whole lot has changed. The population is significantly larger. It doesn't account for different kinds of facilities that have come or gone. If your plan isn't even updated, chances are you're not training to that plan. You're not going to be capable of responding to the really big kinds of things that come along. Now, COVID-19 has been a slow rolling train. So it doesn't roll you over all at once. But there are some events that could absolutely hit our area hard and break the system. If we're this strained, if we're staffed at a third to a half of what comparable agencies are doing, just to kind of get by with the day-to-day work, what happens when there's a really, really big thing that hits? That is what we're worried about. It's the kind of thing where we don't want to be alarmist, and we haven't, this is not about accusing the county of negligence. It's not about any of those kinds of things. This is the kind of issue that usually kind of flies under the radar. It's not one of those high profile, sexy kinds of agencies. There's not a lot of staff, not a lot of issues in the headlines, but it is something that has quiet, indirect, less visible sorts of impacts. And when it goes though, if something bad does happen, it's the kind of thing where everyone's going to be asking, why didn't you do something sooner? And that's why we're here. We believe as the healthcare field in emergency services, be it ambulance providers or hospitals, that the time really has come to staff and budget appropriately so that we can right size Sacramento County's Emergency Medical Services Agency. We recognize that may be the kind of thing that is incremental. You're probably not going to double the staff right now, and budget years aren't good this year or the next couple, most likely. But we think it's a significant enough issue that we need to be prepared. This is about life and saving life, but it's also about the quality of life after a life-threatening situation. And if we're not providing the best medical care and ensuring with oversight and protocols and follow-up and training and data analysis and quality improvement and all those other things that most people don't know about, but that this agency does, then we're just not going to be ready to provide the public what it really deserves. So with that, we've met with the board in a hearing setting. We've had some conversations both with senior staff and some of the supervisors offline as well, really trying to help them understand why this is a problem, why it needs to be rectified. And my ask in coming to you is that you, as an advisory board to the Board of Supervisors, echo our call to right size this agency. You have a lot of credibility in your longstanding advisory board to the Board of Supervisors. And so we're here to answer your questions, to have a conversation about this. But ultimately, I think it would be wonderful if the Public Health Advisory Board echoed our call to the Board of Supervisors to make sure that we address these shortfalls. So as I turn it over for any of your questions, I want to acknowledge that Chief Barbie Law, who's a member of your board, who's with us today, is also a member of the Emergency Medical Advisory Group. And I would welcome you addressing any of your questions or asks for insight from her as well. She's well prepared to respond to this also. All right, I don't know if you want me to field the questions or not, but is it Nanda Kumar? Is that how I pronounce your name? I see your hand up.
Sorry, no, I think that's just his picture.
Oh, that's just he's perpetually waving. Sorry.
Right. Are there any questions for Brian?
This is Larissa. I have a question. You know, as an emergency physician, obviously I see a lot of these patients coming in. What proportion do you think of the increase in volume pre-COVID at least was related to mental health and other opportunities, I guess, to collaborate with other agencies and crisis teams? And I'm just wondering how much EMS is doing that versus, what proportion, as we've seen the mental health crisis kind of escalate, what proportion do you think is related to that?
I will tell you that pre-COVID and post-COVID, and significantly during COVID, the number one problem we're facing is behavioral health. That's mental health and substance use. Those are by far the most worrisome issues for hospital leaders. It's by far what we spend the most time on in our collaborations with other stakeholders, such as our EMS system. We're exploring some really innovative ways of addressing that. And I know the county has some proposals going to the Board of Supervisors right now on how to provide some new and different responses to those kinds of calls in the field also. But one of the key, to answer your question more directly, one of the data pieces that the EMS gathers on a multiple time per day basis is how many behavioral health holds are in each of the hospitals. And that helps us get a look at just how strained our EDs are because of untreated mental health issues that are showing up in the ED because that's really almost the only place they can access immediately. And I want to credit the county for making some real headway in this space. 3 years ago, they opened up the Behavioral Health Urgent Care Center near UC Davis by the Mental Health Treatment Center. They've done a lot in opening up and helping open up new crisis residential units and things like that. So there's a lot of progress in this space, but absolutely part of that increase both in calls and in walk-in volume to our emergency departments is mental health and substance use issues.
Thank you.
Are there any other questions, Steve?
Yes. Hi, Brian.
Hi there. Good to see you again.
Good to see you. I just want to remind the board that just a few years ago, a major focus of ours had to do with what we call wall time, which is how long it takes for ambulances to drop patients off at the emergency departments. And there was such a tremendous backup in the ERs that sometimes the ambulances had to wait for many minutes and even hours to be able to drop their patients off. At that point, PHAB was a major supporter of increased funding for the LEMSA. And we wrote a letter to the Board of Supervisors making that point. And we were also major advocates for the advisory council or group that was eventually set up to look at all of this and to promote communication between the hospitals and the ambulance companies, et cetera. So I would encourage PHAB to support these efforts. I think it's a long time coming to try to help better staff, better fund the emergency medical services agency that we have. Clearly, the numbers show that we're far behind counties that have similar populations and similar services. One thing you didn't mention, Brian, was that despite the fact that the LEMSA has taken on new duties, and that is to monitor stroke care and myocardial infarction care, et cetera. Those are extra duties that were taken on without extra funding, and we really need to catch up.
Yeah, I thank you for bringing that up. Yes, so in 2019, part of the reason for those increased fees and new fees was that the state has mandated new stroke and STEMI programs for each of the hospitals. And so the LEMSA has to oversee that. And when you talk about wall times or ambulance patient offload times, it's been about 4 years now that the LEMSA has been tracking that as well, working with the ambulances and the hospitals to get on the same page on accurately measuring the wall times at each facility and then reporting those times, which can lead to improvement. And we've seen that. We've seen that as just with getting better data and more accurate data, leaders have been able to really see where genuine problems are. And we've seen whether through staffing changes, through protocol changes, through whatever else may be, that we've seen some significant improvement generally, but in particularly some of the facilities where we were having the longest wait times. And so those are roles that, again, very indirect and very intangible to the public, but lead to significant outcomes.
Thank you. Thank you, Steve, for providing the historical context for this. So I'm going to suggest that we take a vote at the next meeting on this proposal. We're going to meet within the next 2 weeks at the latest and get back to you with, I presume, a letter of support.
Well, I appreciate you taking the consideration today, and I know you've got a busy agenda, and I appreciate you, again, considering a letter of support at your upcoming special meeting. Offline, if any of you have questions you would like to ask me about it, or Barbie's among you, and she's really a frontline expert in this field and all these issues, we're happy to respond. And again, I just thank you for your time and look forward to your support, hopefully.
Thank you for coming and presenting and informing us about this, because it is a very critical issue. We appreciate it. Appreciate your work on this. Thank you.
Thanks, Brian.
I just want to also thank Sonal, who was on the agenda and so graciously ceded her time to the next meeting. And we will have an update from the subcommittee on mental health at that time. And we'll do that at the next meeting in 2 weeks. I think that's April 14th, and barring any unforeseen issues, that's when the meeting will be scheduled, and hopefully will be a little shorter. But are there any other comments from actually, let me open it up to public comments. Do we have anybody wanting to comment? I don't see anything in the chat. Any parting comments from the board or suggestions? No, having seen none. Okay. Well, in that case, yeah, I will call the meeting adjourned. Thank you, everyone, for your attention.